So thank you again, everybody, for being here. And I'd like to start off by reminding everyone about our No Pain Conference upcoming on March 26th, 2026. And just a friendly reminder for trainees and early career researchers here in the group to submit their abstracts. We'd love to receive your work and to have you present it at the conference. And the deadline for submitting your abstract is December 3rd. Does anybody have any questions at all? All right. If not, we're going to get started with our lovely speakers today. We have Dr. Emma Duerden and Dr. Jibran Khokhar. And Dr. Emma Duerden will start. So I will introduce Dr. Duerden. So Dr. Emma Duerden is an assistant professor here in applied psychology in the Faculty of Education at Western. And she is a Canada Research Chair in Neuroscience and Learning Disorders. Her research involves pain and early life stress in infants born critically ill, as well as children with neurodevelopmental disorders. Dr. Duerden, thank you so much for being here, and we look forward to your talk.
Yeah, thanks so much, Myrna. It's a great pleasure to be here. So in the speaker series, this focus has largely been on pain in adults, either experimental pain or chronic pain. But today I'm going to be asking you to think about pain a little bit differently. In adults, of course, pain is a subjective psychological experience. But early on in life, in newborns or in infants, pain is really experienced just as nociceptive input. If you think for about a baby who's born critically ill, who's receiving care, intensive care, they're receiving invasive procedures during a time when the nervous system is literally being built. So today I'd like you to think about during my talk, how does early pain and stress exposure impact the architecture of the developing brain? And ultimately, what can these neonatal data tell us about vulnerability, about neuroplasticity, and the long-term embedding of pain across the lifespan? So here is an image of a very preterm born baby, and automatically you're going to notice that every part of the baby's body is being monitored. They have their heart rate monitored, their blood pressure, their respiration being monitored. But the one key part of the body that's not being monitored is their brain. And of course, the brain is really undergoing exponential development during the NICU stay, and that's represented here by these MRI scans taken representing really the third trimester of pregnancy, starting at around 29 weeks up into 42 weeks. And you can immediately appreciate the extraordinary growth that's occurring here in the brain. It's a period of massive plasticity, but also massive vulnerability. And you can see how smooth the cortex is at around 29 weeks, so at the start of the third trimester of pregnancy. And by the time of intended birth at around 42 weeks, you can see all of the cortical folding, the gyri and sulci. And in turn, for very preterm born babies, they are experiencing on average about 200 invasive procedures as part of their life-saving care. And for nociceptive pathways, how the body starts to feel pain, comes online, those processes are coming online in the mid second trimester. But pain modulatory systems, so the ability to endogenously modulate pain, those descending pathways, don't come online till much later, till around the third trimester, the midpoint of the third trimester. So what you have is a developing nervous system that's receiving repeated nociceptive input at a time when the brain doesn't really have the systems in place to be able to regulate or buffer it. And in turn, the earlier the exposure occurs, the more profound the effect in terms of babies' developmental outcomes. And in fact, after decades of follow-up studies, evidence suggests that the NICU experience is associated with alterations in motor and sensory processing, as well as difficulties with reading and writing when they get to school age. Moreover, these babies are also very high risk for the development of neurodevelopmental disorders such as autism and attention deficit hyperactivity disorders. So of course, these disorders will have genetic components, but they're also disorders associated with an early life onset with variable developmental trajectories. And in turn, these alterations can be impacting the same neurocognitive systems that modulate pain, regulate emotions, and support later executive control later on in life. So a key question becomes, could early pain and stress be one of the key early life driver shaping these developmental trajectories? So when we return to our central question that I mentioned at the beginning of my talk, if pain can alter neural circuits in adults, what happens when pain is being experienced before all of those circuits even exist? And what is the long-term impact of early nociceptive and stress exposure? So you may be thinking, how can we even study this in babies who are so young? Well, we scan them with MRI at two time points, one around the time of birth and again at term equivalent age, which allows us to study growth. We can use multimodal neuroimaging methods just as we can with adults. And I'll be focusing on some of these methods during my presentation. We can, of course, study macrostructural growth of the cortex and subcortical regions. We can study white matter using diffusion tensor imaging, functional MRI, just as we can in adults. And we can also study brain metabolism using magnetic resonance spectroscopic imaging. In turn, we can, during their NICU stay, trained nurses, they will record every invasive procedures that the babies receive. So skin breaks, heel lenses, line insertion, intubation, chest tubes, or lumbar punctures, which can give us an objective measure of overall nociceptive load rather than relying on subjective pain scales. We then invite the infants and the families back at toddler age as well as at school age for standardized cognitive and motor testing. And at 8 years of age, we invite them back for another MRI scan. Now, you also may be thinking, how can we study the effects of procedural pain in isolation when these babies are undergoing clinical care? So, and I've listed some key factors on the left side of the screen, which have been associated with alterations in early brain development. So just know that all of the models that I'm showing you today, that we adjust for these major clinical factors, which can influence brain development. Today, I'm going to be focusing on three key subcortical regions, which are especially vulnerable during the preterm period, which are the hippocampus, the thalamus, and the amygdala. So these structures are undergoing really rapid growth between 23 and 40 weeks gestation, and they play really central roles in memory, as well as sensory processing, nociceptive processing, emotion, and early social development. And what I'm going to show you today is that across multiple cohorts, is that in these regions, we see selective alterations in relation to early procedural pain exposure, and that these early alterations can predict later cognitive motor and social emotional outcomes. And by examining each of these brain regions, we can begin to understand how early pain can become embedded in the developing brain. And to put this in context, I'll just show you how rapidly the hippocampus is developing throughout the first 4 years of life. This work was led by Emily Nichols, who's a research scientist with my group. And here, Emily studied over 300 individuals, including healthy fetuses and preterm born babies who were scanned at identical gestational ages. And I've just highlighted here this window so you can see the steep growth trajectory of the hippocampus with the volumes being on the y-axis. You can see that steep growth trajectory during these first few weeks of life and just how dynamic and vulnerable the structure can be during the same period when the preterm born babies will be receiving NICU-related procedural pain. And this is also just showing the amygdala volume. So this is work led by Megan Mueller, who's a PhD student in the lab who teamed up with Emily to show that the amygdala development in similar cohorts of fetuses and infants and toddlers shows actually steeper developmental trajectory, just really highlighting again how sensitive these structures can be when they're being exposed to high levels of procedural pain. So given how rapid the hippocampus and amygdala are developing and their well-known roles as stress-sensitive limbic structures, in these early studies, we initially anticipated these regions to be most vulnerable to early pain and stress. So the first study, we had focused on the hippocampus. In this study, this is a cohort of very preterm born babies born between 23 and 32 weeks of gestation. And they were scanned around the time of birth and again at term equivalent age, and we extracted the hippocampal volumes. We also collected detailed information about all major about all of their invasive procedures, every healant. So this is a healant, a little baby foot here, any type of skin breaking procedures. And we also collected information concerning their exposures to analgesic and sedatives, so midazolam, morphine, fentanyl, and other clinical care factors. And the infants and their families returned in the second year of life and were assessed for cognitive and motor functioning. When initially looking at the hippocampal growth data, which I'm showing you on the y-axis, in relation to the total number of invasive procedures, we demonstrated slower hippocampal growth in those babies who'd received a higher number of skin breaks. However, when running the full statistical models, it became evident that these results were being driven by exposure to a common sedative, midazolam, which is a benzodiazepine given to manage pain and agitation. And in turn, when I'm showing you the same data here on the next slide with those babies who were exposed to midazolam in green, that these data were really driving the results. So it was clear that it was procedural pain. It was rather midazolam and not procedural pain that was driving the reduced hippocampal growth. And this suddenly really made sense, knowing that the hippocampus is one of the regions in the brain that has the highest number of GABA A receptors. So the exact receptors that benzodiazepines bind to. So in turn, this was a bit of a light bulb moment for myself, and that it began to change how I was thinking about neonatal pain and the developing brain, as well as our analgesic and sedative practices. When these babies returned in toddlerhood at 18 months of age, we found that those who'd been exposed to midazolam had impaired cognitive outcomes, but intact motor outcomes. And to follow up on these questions, they returned at school age at 8 years for further scanning with MRI, as well as standardized intelligence testing. We were able to extract the hippocampal volumes just as we'd done previously, and I'm showing that to you here on the y-axis are the whole hippocampal volumes. And on the x-axis is neonatal midazolam exposure, showing clearly that those children who'd been exposed neonatally to midazolam had smaller hippocampal volumes. And when we dug a little bit deeper and we calculated the hippocampal subfields, we found that these results were mainly being driven by volumetric reductions in the subiculum. And those data are on the x-axis here. And the total dose of neonatal midazolam is on the y-axis. We showed that babies who had larger subiculum volumes had received lower doses of midazolam in the neonatal period, while those with higher doses had smaller subiculum volumes. So what is the subiculum? It's a major input-output hub of the hippocampus. We also related these findings to the children's standardized cognitive assessments, and we found that those babies who'd had smaller hippocampal subiculum volumes, who'd been exposed to neonatal midazolam, had impaired working memory ability. So 8 years after exposure to midazolam in the NICU, we were still seeing profound and functionally meaningful alterations in hippocampal structure as well as cognition. So where did this leave us? So our goal at the beginning was to be identifying brain regions that were being affected by procedural pain. But the data from the hippocampus taught us something really important about sedative exposure, but it didn't answer that core question. So our next step was to turn to the thalamus, which is central to nociceptive and somatosensory processing, and is also undergoing rapid development in the preterm infant. So in the same cohort of babies, we subsequently segmented the thalamus, so using the same data set. So we were able to look at macrostructural growth of the thalamus. And we also used deformation-based morphometry, which is a method where you can look at regionally specific changes in volume. This was a multimodal imaging study, so we also collected diffusion tensor imaging data to look at changes in white matter microstructure, and we also were able to look at brain metabolites using magnetic resonance spectroscopic imaging, or MRS. And so we related these changes through to the total number of invasive procedures. Of course, examining analgesic and sedative factors such as midazolam and relating it to the baby's developmental outcomes. When we first examined the thalamic volume data, we showed that the babies who'd received a higher number of early skin breaking procedures exhibited slower thalamic growth, And we subsequently followed this up using deformation-based morphometry, and the results I'm showing you here on the left side of the screen, where the cooler colors here represent decreases in volume in the territory of the lateral thalamus. And I'm plotting the data here on the right side of the screen, just demonstrating significant volumetric reductions in the territory of the lateral thalamus in relation to the early skin breaking experience procedures. So these were skin breaks experienced during the first few weeks of life. We then examined the findings in relation to the data from MRS, magnetic resonance spectroscopic imaging, and we showed this is NAA, that N-acetyl aspartate, which is a marker of neuronal integrity, that we found decreases in neuronal integrity in the NAA values, particularly for early pain exposures. And then we also examined the diffusion tensor imaging data, which allows you to look at changes in white matter. And we found also that in the babies who had received a high number of early skin breaking procedures, they had reduced metrics of white matter microstructure, and reflected here in these FA values. So these are thalamocortical projection tracks. So just to highlight, what we see here in this single cohort, that there were regionally specific alterations in the lateral thalamus associated with procedural pain. And we saw evidence of disrupted thalamic neuronal integrity, as well as alterations in white matter fiber pathways subserving thalamocortical projections. And importantly, all of these changes in the thalamus were not explained by sedative or analgesic exposure. So unlike what we'd seen in the hippocampus, so there's no associations with midazolam. So in turn, overall, this would indicate that procedural pain itself was driving these early disruptions in thalamic development. So we were able to follow up on these thalamus findings in a cohort. This was a collaborative study with our colleagues in Lausanne, Switzerland. And this work was done in collaboration with Julianne Schneider, who's a neonatologist. In this cohort of very preterm born babies, they were actually scanned 3 times during their NICU stay. And this gave us an even more detailed view of early thalamic development. So this was actually a lower dose midazolam cohort, but they had slightly fewer painful procedures, but they did receive other clinical care factors comparable to our Canadian cohort. We were able to follow the babies longer term up until preschool age, and they were assessed on standardized tests for emotional and behavioral difficulties. And when we examined the thalamic data, and I'm showing you that here on the y-axis in relation to age, and these are the individual trajectories of babies exposed to high numbers of early skin breaks, the data in red, we can see that they experienced slower thalamic growth in comparison to babies who'd received a fewer number of invasive procedures, the data in blue. So despite differences in medication exposures compared to our first cohort, the Canadian cohort, the thalamus again showed clear pain-related vulnerability. We had the opportunity as well to follow up on these thalamus findings by conducting another collaborative study with our colleagues at Utrecht. And in the Netherlands, many NICUs, they routinely use what's known as central or arterial lines. So this is an example here of an umbilical line. And they do this intentionally with the overall idea of reducing the number of skin breaks that the neonates will receive. So in turn, this created a natural experiment where we could compare 2 groups of very preterm born babies who were matched on a number of clinical factors, but they differed in their exposures to procedural pain. So in turn, by comparing to our Canadian cohort, the Site 1, we were able to compare the exposures of invasive procedures on thalamic development in the Canadian cohort and in the Dutch cohort, and relate it to comparable measures of motor and cognitive outcome at preschool age. So in this comparison table, I'm showing you the Canadian and Dutch cohorts, so Site 1 and Site 2. And so they were closely matched on all major NICU factors, including birth, gestational age, illness severity, But the key difference, except for mechanical ventilation, which we adjusted for, but the one factor that consistently differentiated the two groups was the amount of procedural pain they received, with the Canadian cohort receiving 3 times the amount of invasive skin breaking procedures compared to the Dutch cohort. And when we examined the thalamic volumes in the two matched cohorts, so that's the thalamic volumes here on the y-axis, we found that babies who'd received the central lines at site 2, who'd had fewer overall painful procedures, they had larger thalamic volumes in comparison to the Canadian cohort of babies who'd received a higher number of skin breaking procedures, but few differences in the thalamic volumes between the babies at both sites. So in turn, providing strong evidence that across countries and NICU practices that reducing early procedural pain could support healthy thalamic development during this critical period. And lastly, I wanted to just highlight to contrast these findings of the hippocampus and the thalamus with another key stress and emotion related structure, the amygdala. So in the same cohort from Lausanne, so this was Julianne and Megan teamed up to assess how to assess both amygdala volumes in relation to later developmental outcomes. We also showed that procedural pain and not sedation shaped the neonatal amygdala volumes, and this was related to behavioral outcomes. So babies who'd experienced a higher number of skin breaking procedures, they showed a stronger association between amygdala volumes and behavioral difficulties at school age. So just as in what we'd seen with the thalamus, that these effects, they were not explained by midazolam or morphine or other clinical care factors, just providing evidence that early pain exposure rather than sedative medications can influence multiple developing subcortical brain regions. So if we return to the central question that I started with, how does early pain and stress impact the developing brain? Across 3 different cohorts in Canada and in Europe, we saw a very consistent pattern that the hippocampus was sensitive to sedatives, not so much procedural pain, showing long-lasting effects into school age. While in contrast, the thalamus and the amygdala showed dose-dependent effects of procedural pain, and this was independent of analgesic and sedative medications. So, and then lastly, NICU practices that were focused on reducing invasive procedures through using central lines, so the example of the Dutch cohort. This was associated with larger thalamic volumes and improved behavioral outcomes later on, just showing that early pain is not benign. It shapes really vulnerable developmental circuits during a really critical period of development, and even small changes in clinical practice could meaningfully support healthy brain development and outcomes in this vulnerable group. And I'll stop there, and I'll thank my colleagues at the Hospital for Sick Children, as well as my colleagues at Utrecht and Lausanne, and I'll thank my current colleagues here in the NICU, the NICU nurses, which make a lot of our neonatal studies possible, and my lab members and the following funding agencies. And of course, to all of the families that participate in our research. And I'll thank the audience for their interest, and I'll be happy to take questions at this time.
Thank you so much, Emma. That was wonderful and very interesting. You gave us lots to think about. So, are there any questions from the audience? Yes.
Yes, Dave?
Yeah, great. Wow. Terrific stuff, Emma. And it reminds me of something that I've come to accept, which is that time does not, in fact, heal all wounds. So now you've given us a biologic basis for that. Now, I'm
That's
curious,
well
I'm
said.
assuming, thank you. I'm assuming that there are geographic differences in the use of pediatric anesthetics and
Mhm.
painful procedures. And so I'm just curious, I'm thinking now from my sort of more social oriented perspective. Do you think that what you've shown here might explain, or would we expect to see, say, differences in, the proportions of adults with chronic pain in geographic regions where anesthetics are not used typically in the neonates?
Yeah. So there have been some studies showing that preterm born babies that can actually have altered pain responses at school age. And whether or not very preterm born babies are likely to develop chronic pain later on, I don't know. That's a
Yeah,
great question.
yeah.
I mean, potentially, right? Because of like these early vulnerabilities. Um, yeah, like for example, there's many countries that they won't use analgesic and sedative practices
Hmm.
in very preterm born babies, and care practices do change a lot. Like every decade or so, like there's changes in care practices.
Yeah.
Yeah, somebody needs to do that 60-year study. We
Yeah,
could
no,
do that
exactly
study,
right.
Dave.
I think we should. Yeah, we'll do our own sort of Framingham type study here. Yeah, I'm just thinking like I've done a bit of work in adverse childhood experiences, but typically those need to be recalled by the now adult
Yeah.
respondent, right? Did you have these experiences early on? So they wouldn't know what happened to them, in the neonatal period. So yeah, anyway, just it got me thinking
Yeah,
about whether
yeah.
this
Like
could be a
ACEs,
mechanism.
like adverse childhood
Yeah,
experiences, yeah, have definitely they're involved in chronic pain generation in children, right?
yeah,
So yeah, so that's certainly true. But those measures are typically done, kind of more recently, and they're looking more
yeah,
broadly, like
yeah.
at social factors. Yeah, so I mean potentially they could be like for preterm born babies, they could be at risk, but they also have such variable developmental trajectories as well. Like there is so many resilience factors too. So it's pretty difficult to
Hmm.
disentangle. Yeah.
Yeah,
But
no, for sure.
great
All right.
question. Thanks
Well,
so much, Dave.
we we've got a project to work on. Thanks.
We'll go into the next talk, and I will start by introducing Dr. Jibran Khokhar. So, Dr. Jibran Khokhar is an associate professor here in the Department of Anatomy and Cell Biology at Western. His research involves understanding the mechanisms underlying mental illnesses and substance use disorders using a variety of behavioral, pharmacological, and translational neuroimaging techniques. Thank you so much, Dr. Kokar, for agreeing to speak here today, and we look forward to your talk.
I should have gone first. Emma's the hard act to follow, especially with all the cool data that she had. I have less data in the talk, but I do think that what the what we have found in translation, this part of the title could even help understand some of the effects of early pain management and anesthetic use, and maybe some rodent models could be useful in trying to understand some aspects of it, at least the causal impacts of it on brain growth and development. And so maybe we should talk about that. But it's great to be here. No Pain's awesome. And the topic today works out really well with one of our keynote speakers at the No Pain Research Day, Hans Clark, who's kind of the cannabis and pain guy. And so please come and listen to him. He's wonderful. And I get to work closely with him at the Canadian Consortium on Investigation of Cannabinoids, and he does some really impactful work. And so I'll get started with my presentation now. Before I start, some of the work that I'm presenting today was performed both in Guelph and in London on the traditional lands of the Mississaugas of the Credit, First Nation of the Anishinaabeg people, the Haudenosaunee, the Lenapehoak, and the Chinooka nations on lands connected with the Dish with One Spoon Covenant Wampum. And as neuroscientists, while we try to figure out the most complex problems or questions with our brains, we often forget that neuroscience is done by flawed human beings, us, and sometimes neuroscience has been and continues to be used to uphold systems of racism and colonialism. This is not something we shy away from, but instead, we can move forward with humility and see how we can contribute to understanding and mitigating the long-term consequences of settler colonialism and genocide on the brain, body, and society in Canada and across the globe. And with the topics that we're talking about today, cannabis and pain, both of those also need this true look through the truth and reconciliation lens, because of the harms perpetrated through the criminalization of cannabis and other things over the years on the Indigenous populations. So cannabis is the topic today. I started my lab January 1st, 2018. And it was high time to study cannabis in Canada. There will be a liberal sprinkling of dad jokes throughout. It comes with the territory. But October, so just 20 days ago, would have been 7 years since we legalized cannabis in Canada. And even before legalization, we were some of the heaviest users of cannabis worldwide. And post legalization, that has stayed the same. So if we look at past 12-month use in Canada, over a quarter of Canadians report using cannabis in the past 12 months. But beyond that, when you look at certain age groups, the rates are much higher. So that 16 to 19-year-old demographic, over a third of Canadians reported using cannabis in the last 12 months. In that 20 to 24-year-old demographic, it's 50% of Canadians. And then as you get older, it's around that quarter mark. And what's interesting about cannabis compared to other legal substances that are available in Canada is the perceived risk associated with it and the perceived benefits associated with it. And I think that's what we'll talk about today. Because if you compare it to, tobacco smoke and alcohol, which we know have as harms associated with them, can be even compared to something like e-cigarettes, which really took off because of their perceived safety profile compared to other types of tobacco use, for example. Cannabis generally is perceived to be safer, and this perception of safety is continues to increase in terms of the proportion of the Canadian population that perceives cannabis to be safe or associated with little risk. But beyond that, I think the important piece is the medical use of cannabis. And while there was this real hope around when legalization happened in Canada that this would become a multi-billion-dollar industry around medicinal cannabis in Canada, and it would that didn't really happen. In fact, most of the companies that had started off trying to capitalize on this medicinal cannabis industry actually ended up going recreational because that's what took off in the wake of legalization. But this is a recent report from the CCAC, the Canadian Center for Substance Use and Addiction. And they've talked about the medical use of cannabis and cannabinoids and really trying to clear the smoke on it. And this part really stood out to me. In all the surveys that they've done of medicinal cannabis use across Canada, pain seems to be the most common medical reason for cannabis use. Unfortunately, this is still something that we don't study all too often. And even when we look at how people are using cannabis, that seems to be changing year from year. And even though we've had now clinical trials across multiple studies and multiple continents, we have some reports, at least in a recent Nature Medicine paper. But aside from that, the studies haven't really shown a clear effect of cannabis in pain management. And I think it's important in terms of considering how we study it, how are people using cannabis, and what has actually been tested in clinical trials or randomized clinical trials so far. So some of the data that we know around how people for medicinal, this is not just specific to pain, but for medicinal purposes, how they use cannabis, it really comes in a variety of forms. And so some people are smoking and eating, others are smoking and vaping, and others are smoking and dabbing. And then depending on the how many of them are using each form, like people are using different types of cannabis in different ways to help with whatever their medicinal cannabis concern is. And so this is something we've tried to model in animals. For a long time, we've seen signals around anti-nociception from cannabinoid compounds. In fact, when we look at the effect of a cannabinoid in an animal model, we have something called a behavioral tetrad. A tetrad is 4 behaviors that are characteristically known. If something is acting as an agonist at the CB1 receptor or the cannabinoid receptor, these are the 4 things that we measure. And so it's hypolocomotion, hypothermia, catalepsy, and the 4th thing is anti-nociception. So one of the things that we test when we know something might be acting through a cannabinoid mechanism is look at perception of pain and latency to show a pain response. And so this is something that we've known for a while, but a lot of these studies were done using injected pure agonists of the CB1 receptor like Win or others, or even if THC was used, it was used and injected and often given at doses that are much greater than what you might get from how people use cannabis. And so this is something that we've been trying to approximate in the lab. And that's where part of the title comes from. What we found in reverse translation, I guess, is trying to take what we know from how humans use cannabis and trying to bring it back to the lab. And so one of the ways we've done that is by using a volcano vaporizer. For those who might not know it, it's the OG cannabis vaporizer. It was often referred to as the Ferrari of vaporizers because it was more expensive than other vaporizers. And for those that haven't seen one in the past, they actually there's a bag that would fill up with cannabis vapor, and then you would sort of puff pass it amongst your friends. But post COVID, people stopped sharing the bags, and that's when this whip attachment that you see really took off, was during COVID. And so we took the whip attachment and we attached it to a cage in which now we can put in different types of cannabis into the vaporizer and vaporize it directly into the cage. This kind of like hotboxing with your friends. So there's, at any time up to 16 rats in there, and they're getting exposed to cannabis vapor directly from the dried flower. And so this is dried flower that is available from the Ontario Cannabis Store. We actually look up the Yelp reviews or the reviews on the Ontario Cannabis Store to find what it is that humans are using. What is popular? What is it being used for? Are they saying they're using it for pain, or are they using it for other things? And so we can actually go by what is what the reason for use is, and we end up buying directly from the same cannabis that would be available or would be used by humans, and in this case exposing animals to it. In this case, this was a study done in adolescent rodents when they were exposed during postnatal age 28 to 42, and we were looking at the long-term effects. But there are pieces that I wanted to show from the data in these animals that's important in the context of what we're talking about today. This is for 0.25 grams of cannabis exposed to, up to 16 rodents. And it's once a day, and it's a 15-minute exposure. So this isn't, high levels of cannabis. This isn't, honking big doses that were usually used in those injectable studies. But even then, at these relatively low doses, and it's important here, the controlled nature of those injections that we talked about before is that that the drug is getting in. Here, when it's vaporized, the animal can go stick its nose where the vapor is coming out, or they can go to the opposite direction. They can hold their breath, or they can increase their breathing rate. And so they have volitional control on this. And so it's important to always anchor this to real measures, pharmacokinetic measures, where you're measuring how much of the drug gets into the bloodstream. And the single exposure once a day produces relatively low levels of THC, which is the primary psychoactive cannabinoid in the cannabis plant. But for the most part, those labels on the products that we were getting from the Ontario Cannabis Store, in fact, hold true. The high THC cannabis produced the highest levels of THC and its active metabolite, 11-hydroxy-THC. The high CBD cannabis produced the highest levels of CBD. And when we measured the tail flick latency, which is a measure of anti-nociception in these animals, we are basically shining a light that's results the tail to heat up. When do the animals actually flick it, and how long does it take? And we see that when they get the high THC, even though it's a 10 to 12 nanograms per mil, which is roughly what you might get from one inhale from a cannabis cigarette. Even at those low levels, you can actually see a measurable increase in the tail flick latency. So even these low levels of THC exposure produce changes in anti-nociception. And an important thing here, and this is what I wanted to share, is that in the males, it's clear that the high THC produced increases in tail flick latency, but in females, even the balanced and the high CBD form produced measurable changes in tail flick latency. And so even when we're doing sex difference studies, it's important to recognize both the pharmacokinetics of it, how does the drug get into the body, but also the pharmacodynamic effects, where the same dose of the drug may produce very different effects in male versus females. And this is important when you consider some of the epidemiological literature that suggests that women may use cannabis more in terms of both how the types of cannabis they use, edibles versus vaping, but also when it comes to medicinal use for pain, etc. And so it's important that we're capturing this in our animal models as well. The next thing that I'm going to talk about is edibles. And again, there's a lot of information and sometimes misinformation out there as well around edibles. Cannabis edibles can ease pain and improve sleep for cancer patients. So it's a recent headline, but there's a lot of, and oftentimes when I tell people I'm a cannabis researcher, that's the first thing they ask me about is cannabis edibles. How much should I take? What's the good dose? I need it for my knee pain and need it for my wrist pain. And so there's all sorts of questions that come around that. And so that's something else that we've been trying to model in animals. And again, we try to stick closely to how humans use it. And so Zamnesia, for example, has a really nice recipe for cannabis-induced Nutella, cannabis-infused Nutella, and rats love Nutella. And so we can just go to the Ontario Cannabis Store, get a full spectrum, so it has all the things that are in the THC, in the cannabis oil, but also a known amount of THC, and we can just mix it with the Nutella and then assess the intake of Nutella in these animals. We look at pharmacokinetic measures, pharmacodynamic measures, as well as neural activity recordings, and I'll present some of that data in the coming slide. And so we see that, compared to even what I was showing earlier, the edible doses actually produce significant sex differences in how much THC is absorbed into the body, but also how much of it gets metabolized to that active 11-hydroxy-THC compound. And this is because it's an edible dose, a lot of it is going through that first pass effect. And it produces much higher levels of THC and 11-hydroxy-THC even in the brain, and the drug is still there up to 24 hours later. Well, what's really cool is that even on the tail flick latency piece, we see significant increases in tail flick latency that last up to 24 hours after a single dose of the cannabis edible. And so again, this is something that we're trying to continue to work on. And as Emma was talking about with the MRI, we're also trying to now understand what the neural basis of this is. And so recently we've now established a method where we can have animals that are restrained in the MRI without needing an anesthetic, even an anesthetic to place them into the magnet. And these animals are basically for up to 2 hours. They've been trained to keep their head still and not and be relatively stress-free. We've measured court levels, and they're doing okay in there. And because previous studies that we've done with the MRI, the animals had to be sedated and had anesthetic. That would obviously interact with the effects of cannabis. And so here this is our first study. We've just piloted this in 5 animals, where we've trained these animals to stay still in the magnet and then allowed them to eat the cannabis and Nutella mixture and then scan them. And so this is some of the hot off the press data that I wanted to share. These are the before and after heat maps, but we see a pretty brain-wide change in connectivity patterns. This is a network-based statistical analysis that we've done here, and some of the brain regions that are impacted by this cannabis edible include your ventral striatum, the nucleus accumbens, the inferior colliculus, the cingulate cortex, which is an important brain region when it comes to pain and chronic pain as well, and insular cortex. And what's really cool about this is what the cannabis is doing. And what we see is that there are these positive correlations that exist before between some of these nodes. So, for example, the accumbens shell to the insular cortex, the cingulate to the hypothalamus, and then after the cannabis exposure, they're flipping the direction. It's almost now it's becoming an anti-correlation. So now we're hoping to continue to study this further to try to understand what is happening at the level of the brain after cannabis edible, cannabis vapor exposures, and other things. And an important thing that we've been trying to figure out is with the recent rise in cannabis poisonings that has also been seen in kids in recent years, we've now also created a model where we've got juvenile rodents taking what would be essentially a chocolate bar full of THC, not knowing that it contains THC. And we see long-lasting effects of a single exposure to a 30 mg per kg dose of THC. And we see that, body temperature changes are seen up to 24 hours after a single dose. The animals are not moving a lot up to 14 days later, even so significant reductions there with some clear sex differences between the males and females. But again, that tail flick latency, we see after a single exposure up to 72 hours later that they're still showing an increase. And even up to 14 days later, while it's not as high as it was right after exposure, those animals that were exposed to the cannabis edible show an increased tail flick latency. And so, again, it's important to be considering how cannabis might be interacting with the perception of pain and how it even might impact animals or humans that have a cannabis poisoning incidence. And one of the interesting things that I don't have data on here is that even when we take these juvenile animals that were exposed once and then test them again in adulthood, now exposing them to cannabis vapor, for example, they show a heightened anti-nociceptive response to THC compared to animals that weren't exposed to cannabis. And so this is the last thing, I had genetics in the title, so I wanted to just touch upon this as well. There's a lot of conversation now around, do you love weed and does genetics have anything to do with it? And so there's this gene called CADM2 that even Instagram folks are talking about. And again, this gene comes up as in recent articles around can't stop popping THC edibles, your gene might explain it. And so this is something we've been trying to look at and have been interested in this gene, the CADM2 gene, in the lab, which came out right as I was starting the lab. And GWAS studies are kind of like finding a needle in a haystack, right? Like there's hundreds of genes that show up to be significant. But we were hoping that if it's that far above the y-axis, maybe it's worth betting the farm on, or at least trying to figure out what this gene does. And so we've since this is a paper that just came out from our lab where we've looked at this gene is a significant hit for cannabis use frequency as well. In the past, it was lifetime cannabis use. Lifetime cannabis use isn't the most accurate measure. It's basically asking, have you or have you not used cannabis in your lifetime? And so since then, we've shown that even frequency of cannabis use is impacted by this gene. And so what we've done is taken a mouse in which we've knocked out this gene and then looked at whether this animal likes or dislikes cannabis. And in humans, it's the higher expression forms of the variants that have more preference for cannabis. And so when we knock it out, we see that these animals now show decreased preference for cannabis. So this is the knockout animals compared to the wild types show decreased, and this is for pure THC. When we give them cookie dough with cannabis oil in it, again, we see this decreased preference in the animals that had the gene knocked out, and even those hets that have one copy of the gene knocked out, as the dose of THC increases, they also show that reduction in intake. But what's also really cool is when it comes to cannabis oil containing cookie dough, the females show greater preference for it compared to the males, which is happens to be the same as what's seen in humans. And so again, mice aren't little humans, but we're hoping that if we can do brain imaging on them and their behaviors start to look like the behavior of humans, maybe they're not such bad models for humans. And the cool thing about this gene, and I'll end with this, is not only is this gene involved in substance use, but the gene also shows up as a significant hit in the co-occurrence of substance use and and chronic pain. And so we know that there's a high genetic correlation between multi-site chronic pain, alcohol use disorder, and cannabis use disorder, which is what you see here. And depending on what substance it is, those correlations are pretty substantial. So for example, you can see here, compared to opioid use disorder, where it's not a significant correlation, or in terms of exposure, chronic pain, and then the outcome being substance use, you can see that for chronic pain to then leading to an AUD, alcohol use disorder, or cannabis use disorder outcome, you can see that that direction and the effect is pretty strong, suggesting that chronic pain may be leading from a genetic perspective to genetic risk for chronic pain may be leading or contributing to the genetic risk for cannabis use. And what's really cool here is both for multi-site chronic pain and alcohol use disorder, the CADM2 gene, and then cannabis use disorder, the CADM2 gene again is a significant hit. And so we've been trying to use this model, both the knockouts, to look at pain, at least in the context of the tetrad. And so here we assess them at baseline and then after acute and chronic THC treatments. And what we see with the latency to show pain, that at baseline, these knockouts are already showing a greater latency to show pain. So they can tolerate pain longer than the wild type. So even just knocking out this gene changes the pain perception in these animals. But when we give them THC, either at a low dose, so at a sub-threshold dose of 3 mg per kg or a full threshold dose of 10 mg per kg, we see that these animals, the knockouts, are responding differently, where the wild types and hets don't show increases in latency. The after 10 days of treatment, the knockouts show increased even at a sub-threshold dose, a dose that would normally not produce analgesia in normal or wild type animals. At the high dose, we see, oh, oh, sorry. I think we're all getting an emergency alert. So at the high dose, we see all animals show increases in latency, so we didn't see any genotype differences there. And this is the last piece of data. We had now also have a humanized rat model where we've deleted or recursive splice site variation in the gene, which in humans at least has been associated with a 42-fold increase in the risk for ADHD. And so we're testing this animal model for ADHD like symptoms, but even when we look at tail flick response and hot plate response, we see significant differences between the genotypes. So even not a full knockout of the gene, but just deleting one splice variant of the gene produces measurable differences in the pain perception in these animals. And so, I think what we're now able to do is maybe try to make sense of some of those genome-wide association study findings and get at the mechanistic, the causal basis of the contribution of some of these genes. And as we continue, we're hoping that in the future, we can have rats self-administer cannabis that might have, chronic pain either through a procedure like a nerve ligation or other forms of chronic pain that then we can assess, let them decide how much cannabis they want to take and how does that change their pain perception. But also in collaboration with Dave Siminovitz, we have a marmoset model of TMD pain, and we have also tested in collaboration with Andrew Brzezinski the effects of vaporized cannabis in these animals. So hopefully that's something else that we'd be able to do in the future. And thank you all for being an attentive audience, to all the lab for the work they do and all the funding sources, and I'd be happy to answer any questions.
Thank you so much, Dr. Khokhar. That was very interesting and very humorous. So thank you for that. All right. Questions from the audience.
Jibran, I have a question. We don't have that much time left, so I'll ask it really quick. So one of the things, I went to one of Jamie Seabrecht's talks recently, and what he said was that in London, Ontario, we have a higher number of dispensaries than in the entire province of BC. So it's clearly being used a lot here.
And
One of the things he
Ontario
also,
did a, yeah, sorry. Ontario was weird in its rollout of dispensaries. And so we have a proliferation of them. And that's, you actually see even between Quebec and Ontario, you see half the number of pediatric poisoning cases in Quebec because they kept it centralized and as it like the LCBO, and they only uh, legalized types of cannabis edibles that wouldn't be um, appealing to children. And so there's real consequences of policy at
Mhm.
the provincial level that changes cannabis risk as well.
Yes. Yeah, well that's what the talk was about. It was about, yeah, like poisoning in children. But yeah, the other thing that he noted was that the amount of THC in cannabis products now is like 400% more than it was like in the 80s or 90s. So in your studies, is this kind of comparable? Like, are you doing like mega heavy THC that would be like comparable to what people are receiving like right now, or lower doses like so and how do you kind of keep up with that like research
Yeah, no,
wise?
that's a great question. And because we're so focused on using the cannabis that the people use, we're going by where the market goes, right? So that high THC cannabis was around 20 to 24% THC. And so that's the average going high THC cannabis rate. But in addition to that, we're also testing, in fact, I have a vape pen sitting on my desk right now that this is what you can use with shatter and dabs. And so we've also used the high THC forms of cannabis that are now available
Mhm.
in vape pens, like the 510 cartridges that you can use where these are like 100% THC. So we're testing those effects right now too. I just don't have the pain data, so I didn't show that today.
Great, thanks.
Jibran, I have a question as well. I'm wondering if cannabis works differently for different pain conditions, just from your knowledge, from your own research and from the literature.
Yeah, no, there is definitely differences there, and there's even differences within cannabis. So CBD might work better with inflammatory related pain conditions compared to THC for others, and so there are real differences there. And I think Hans will be the right person to talk about it when he is here. But that is known in the literature that depending, and even bud tenders will actually tell people different types of cannabis, and it's not all of it is always based in evidence, but they'll be like, you should try this, or for your knee pain or hip pain. And so that there is that difference. And then there, as somebody just mentioned in the talk, there are these other more minor cannabinoids. It's not just about THC and CBD, CBG, CBN, CBC. Those have also been shown, at least in animal models, to have analgesic or antinociceptive effects. And I think that's the hard thing when it comes to the plant, is you can't separate out the CBC from the CBG from the THC from the CBD, and that's you're getting the entourage effect, as they call it, but you're getting the cocktail, right? And that's the difference in the plant versus the pure compounds.
I see. Yes. Thank you. And there is a question from Angie here in the chat. She's asking, I heard that CBN also has effects on pain relief. Have you studied these minor compounds in cannabis?
We have not studied the CBN or CBC or CBG. The only one that we've studied is what's called THCV, tetrahydrocannabivarin, and that did show equally as potent antinociceptive effects without. So we did it in a discrimination study, and the animals could discriminate between THC and THCV. So it didn't have the same psychotropic effects, but it did have the analgesic effects. And so that's something we're trying to follow up on now in the lab.
Okay. Okay, thank you so much, Jibran. So just to be mindful of your time and everyone's time, I will end the session here. So again, thank you, Jibran and Emma, for speaking to us today and for your sharing your fascinating research. And thank you everybody for attending. Have a great day, and we'll see you all next month.